today's discussion, we'll have a brief introduction. Then we'll discuss about epidemiology, classification, risk factors and pathogenesis, lactovirus configuration and syndrome, differential diagnosis of primary angle-closure disease, management of specific cases and recent studies, aqueous misdirection, and then we'll have a quick recap with case discussion. Angle-closure disease is responsible for nearly half of world's blindness due to glaucoma. Majority of patients with chronic angle closure remain asymptomatic. Primary angle closure disease is characterized by mechanical blockage of the trabecular meshwork by the peripheral iris, which can be appositional or synovial, in an anatomically predisposed eye with no identifiable secondary pathology condition. Coming to the epidemiology of primary angle closure disease, it predominantly affects the Asian ethnicity more than the Caucasians and Africans. Dimetol, in their systematic review and meta-analysis study, concluded that Asia accounts for 77% of worldwide primary angle closure glaucoma cases. In 2013, among 20.17 million primary angle closure glaucoma cases worldwide, 15.47 million cases were in Asia, and it is estimated that 17.96 million among 23.36 million in 2020 will be in Asia, and in 2040 it will be 24.5 million out of 32.04 million primary angle closure glaucoma cases worldwide. Coming to the major epidemiological studies conducted in India, according to Vellore Eye Survey, the prevalence of primary angle closure glaucoma was 4.3%. In Andhra Pradesh Eye Disease study, it was 1.08% in the urban population. According to Chennai Glaucoma study, the urban population had a prevalence of 0.88% and the rural population had 0.87%. According to Aravind Comprehensive Eye Survey, the prevalence of primary angle closure glaucoma was 0.5%. Chennai Eye Disease Incidence Study, which was a 6-year study, showed an incidence of primary angle closure disease 4% and 1.1% of primary angle closure and 0.3% of primary angle closure glaucoma.
So in these studies, what you, can you go to the previous slide, Catherine? What you can see is that most of them have around 1 or less than 1, except for the Vellore Eye study. The reason for this being the different inclusion criteria for primary angle closure glaucoma. As the Vellore Eye study was conducted before you had the classification to angle closure suspects, angle closure and angle closure glaucoma, a lot of the primary angle closures were also included, which is why you have this 4.3%. Later on, when they had revised the category, the diagnosis, it was found to be similar to the Aravind study of around 0.5. Yeah, continue, Catherine. So when you're reading a study, make sure that you look carefully at the definitions, not just the results, as also at the definition of what comes in a particular criteria. Yeah.
Primary angle closure disease can be classified as primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. Primary angle closure suspect is defined when there is 180° or more of iridotrabecular contact on gonioscopy, which is done with eye in primary position without compression under appropriate illumination, normal intraocular pressure and optic disc, with no peripheral anterior synecdoche. Primary angle closure is defined when there is 180° or more of iridotrabecular contact with elevated intraocular pressure or peripheral anterior synecdoche with normal optic disc. And primary angle closure glaucoma when there is 180° or more iridotrabecular contact with elevated IOP or peripheral anterior synecdoche with optic neuropathy. Coming to the risk factors of primary angle closure disease, the prevalence varies according to the race and ethnicity. In Eskimos, the most common prevalence was seen in Eskimo population. The prevalence varied between 2.6 to 5%, and in Taiwan it was 3%. Indian population showed 3.87%, and Caucasian 4%. As age advances, the incidence of primary angle closure disease increases due to the increase in thickness of lens and the zonular laxity. There is a female predilection for primary angle closure disease, and family history is also found. Ocular biometrics like anterior chamber depth, thick lens,
Catherine,
anterior position of
your voice is not clear. Can you just go a little closer and present?
Okay.
Yeah.
Ocular biometrics like anterior chamber depth, thick lens, anterior position of lens, increased anterior curvature of lens, short axial length, small corneal diameter and radius curvature has also been proved as risk factors for primary angle closure disease. Coming to the pathogenesis of primary angle closure disease, the mechanism can be broadly classified as pupillary block and non-pupillary block. Pupillary block is the most common form of angle closure glaucoma. Increased contact between the posterior surface of iris and lens, anterior surface of lens, and the resistance of flow of aqueous from posterior chamber to anterior chamber is exacerbated with dilatation of pupil, causes the increased fluid pressure in the posterior chamber, which leads to forward shift of iris and angle closure. This is the ultrasound biomicroscopy of angle closure before and after peripheral iridotomy. The first image shows closed angle and pupillary bowing, and the second image shows flattening of iris and widening of angle after the laser peripheral iridotomy.
So you can see in the left image that there is the iris contour is curved. That is the posterior iris is curved. So that is the pupillary bowing. And the same patient following YAG-PI, you can see a flat iris plane, which is the resolution of the pupillary bowing, as the pressure difference between the posterior chamber and the anterior chamber has gone down due to the patent iridotomy.
Coming to non-pupillary block, it can be due to plateau iris, lens-related, or peak peripheral iris roll or peripheral iris crowding. In plateau iris, the anteriorly rotated ciliary process will cause crowding of angle leading to angle closure. Relative anterior lens position or increased lens thickness and increased lens fold will push the iris forward, leading to angle closure. In thick peripheral iris roll, thick peripheral iris or anteriorly located peripheral iris on dilatation rolls into the trabecular measure, causing angle closure.
Okay, can someone tell me what the lens vault is? Anybody? Is Pallavi there? No? Okay. Anjali?
Yes, ma'am.
Yeah. Tell me.
What is the distance between the line joining from the scleral spur?
The line joining?
The scleral spurs.
Yeah.
And the lens, the anterior surface lens.
So you have a line joining the scleral spur
Yes,
and a perpendicular distance from the anterior lens capsule to this line is the lens vault. Okay.
Yes.
Okay. All right. So if the lens vault is more also, in a lens with the same thickness with a more vault can have shallower angles. Yeah, please continue.
Coming to plateau iris configuration and plateau iris syndrome. Plateau iris configuration patients are usually younger than primary angle closure glaucoma patients. There will be occludable angles on gonioscopy with flat iris plane and relatively deep central anterior chamber. The prevalence of plateau iris configuration in primary angle closure glaucoma patients was found to be 30%. Pupillary block is also involved in majority of the cases, which is relieved by peripheral iridotomy. Gonioscopy shows iridotrabecular apposition, flat iris plane, and double hum sign on indentation. Ultrasound biomicroscopy shows ciliary process anteriorly directed supporting the peripheral iris root with steep rise from the point of insertion, iris contact with the angle structures, and absent ciliary sulcus. Plateau iris syndrome is defined when plateau iris configuration is accompanied by elevated intraocular pressure on dilatation in the presence of patent iridotomy. Coming to the differential diagnosis of primary angle closure disease. Secondary angle closure due to iris membranes, as in neovascularization of iris, epithelial downgrowth or fibrous ingrowth, iridocorneal endothelial syndrome, contracture of inflammatory presbyteals, accentual Drager syndrome, peripheral anterior synecdoche following anterior segment surgery. And secondary pupillary flow due to uveitis with posterior synechiae or lens related, which includes phacomorphic ectopia lentis, microspherophakia, aphakic and pseudophakic angle closure glaucoma. Various retinal conditions leading to forward shift of lens iris diaphragm, which includes ciliary body edema with or without uveal occlusion, intraocular gas or silicon oil, resistant fetal vasculature, suprachoroidal hemorrhage, intraocular tumors, etc. And aqueous misdirection and anorthosis are also other differentials.
Okay, so other than these conditions, is there anything that has been missed out in this? Exam going pages? Anyone? Okay, I'll make the question easier. What is the differential diagnosis of a patient with plateau iris, like double thumb sign, and all? What other condition can you think of? Okay, you have to think of a pseudoplateau iris where they can have ciliary body cysts, as a result of which you have anteriorly placed ciliary body-like position. And
iris root cyst.
Yeah, an iris cyst is a different thing. A ciliary body cyst will cause a rotation. You have multiple ciliary body cysts. An iris cyst, a single one, can cause a localized elevation of the iris. And one of the things that you should look for in iris cyst is rule out any tumor or mass lesions. Whereas the second thing that I want to know is, can you get a angle closure disease in pseudoexfoliation? Anybody? Has anyone seen a shallow angles in a patient with pseudoexfoliation?
Yes.
I want to know the reason why. Yes, who said yes?
Ma'am, Pallavi here.
Yeah, tell me.
Hello.
In pseudoexfoliation, how do you get shallow angles?
Due to zonular weakness, there can be anterior subluxation of the lens, and hence it can
Yeah, due to zonular weakness, the lens will move forward, and as a result, there will be shift of the iris lens diaphragm. Yeah, yeah. Due to zonular laxity.
Anterior.
Okay, please continue, Catherine. I think your voice is not very clear. Just see if you can change your position and if it becomes clearer.
Okay. Among the different modalities available for detection of angle closure, gonioscopy is considered the gold standard with a sensitivity of 99 and specificity 95. Coming to the management of specific cases, scenario 1. A 50-year-old female presented with sudden onset pain, redness, and blurred vision in the left eye. On examination, left eye showed circumcorneal congestion, corneal edema, shallow anterior chamber, mid-dilated, vertically oval unreactive pupil, and few anterior subcapsular lens opacities. Intraocular pressure was 54 millimeters of mercury in the left eye and 18 in the right eye. On gonioscopy, left eye showed 360-degree angle closure, no opening or indentation. Trabecular measure pigmentation was 1+, with no peripheral anterior synechiae. Right eye showed occludable angles. Optic disc of both eyes were normal. These are the anterior subcapsular lens.
This is not the picture of this patient. This is a picture of another patient showing a characteristic feature you expect in a acute angle, post-acute angle closure attack. Can someone comment on the picture? If you look at the yeah,
Ma'am, it's a colored slit lamp photo, slit image, showing the peripheral iris endothelial touch, and there is a whitish opacity on the anterior lens capsule, suggestive of glaucoma flectans.
It is a glaucom flecken, and that is the main thing that is being shown. Yeah, you can see a little bit of dusting as well as pigments on the lens capsule also. And another thing to notice, what are the other features that a patient with acute angle closure will present with, the ones that have not been mentioned here? Second years?
Ma'am, no, had unilateral headache. There will be vomiting.
Yeah. Yeah. So sometimes the patient may present with headache and vomiting.
Severe pain.
Sorry?
Lid edema, conjunctival chemosis.
Yeah, conjunctival chemosis and circumcorneal congestion and conjunctival. Okay, more prominent than that, patient will present with uniocular, we can present with headache and vomiting. As a result, the patient may present to a physician first. So ideally, they should not miss it. But more importantly, if a patient presents to you with headache and has similar signs like this, you should definitely not miss it. Okay. And yeah, continue. We'll go on to the management.
Coming to the management of acute ankle closure crisis, the mainstay of treatment is to reduce the intraocular pressure, reduce intraocular inflammation, and relieve the pupillary flow. For the reduction of intraocular pressure, we can use systemic IOP lowering agents like intravenous mannitol 20% at a dose of 1 gram per kilogram or 5 ml per kilogram, or oral acetazolamide 500 milligram, or oral glycerol 50% at a dose of 1 gram per kilogram or 2 ml per kilogram. Topical aqueous suppressants like alpha-2 agonist, beta blocker, and prostaglandin analogs can be used. Topical pilocarpine 2 to 4% once the IOP has been sufficiently lowered, because at high pressure there is pressure-induced sphincter paralysis. And for reduction of inflammation, topical steroids should be started. Most commonly, prednisolone 1% is used. Once the intraocular pressure is sufficiently lowered and the inflammation is subsided, we can go ahead with laser peripheral iridotomy for relieving the pupillary flow. Laser peripheral iridotomy should be done for the fellow eye also. Iridotomy in conjunction with medical therapy successfully aborts the attack in majority of cases and requires follow-up. In case of poor visibility due to corneal edema and failure to control IOP by medical methods during acute attack, organ laser iridoplasty or paracentesis can be done. Placing contracture burns in the peripheral iris mechanically pulls the iris away from the trabecular measure, opening the angle and reducing the intraocular pressure in organ laser iridoplasty. It's also useful when conventional treatment is not tolerated or not effective as expected. In paracentesis, a 27 or 30 gauge needle with bevel up enter anterior to limbus with tip directed between cornea and iris. This will lead to decompression of anterior chamber, leading to immediate decrease in intraocular pressure and relief of symptoms. The potential for complications like damage to lens and infection should also be considered.
Though these methods have been described, more commonly once you give systemic mannitol and aqueous suppressions and then you start off pilocarpine, you are able to do a laser peripheral iridotomy. These are given. Next slide, please. In cases where you are not able to control the pressure, or in scenarios where this is not possible, that is when you consider these. But as they have their own complications, it's not very commonly done.
Once the medical management and laser peripheral iridotomy is done, we have to check the IOP control. If the IOP is controlled on medical management, we can follow up the patient on regular basis if there is no cataract, or if there is visually significant cataract, we can go ahead with phacoemulsification. If there is poor IOP control on maximal medical treatment, assess the extent of peripheral anterior synechia and disc damage. Then, based on the lens status, if there is no cataract, go ahead with trabeculectomy. And if there is cataract, we can do combined procedure as phacotrabeculectomy. Certain drugs can precipitate acute angle closure. The most commonly used drugs are anticholinergic and adrenergic mydriatics like phenylephrine, tropicamide, atropine, hometropine, cyclopentolate, and certain drugs with anticholinergic side effects like ipratropium, antidepressant agents, antihistamines, antipsychotics, and other drugs like topiramate and sulfatrix.
So the mechanism of IOP spike caused by topiramate and acetazolamide are different from those that are caused by drugs like phenylephrine, TCA and SSRIs. In topiramate and acetazolamide, it is not something that can occur in predisposed eye. Rather than that, it occurs as an idiosyncratic reaction where there is ciliary effusion and forward pushing of the iris lens diaphragm, as a result narrowing the angle and which may result in a spike. Okay, continue.
A few words about peripheral iridotomy using NDR laser. The procedure is done under topical anesthesia with topical alpha-2 agonist. Abraham iridotomy lens, which is a 66 diopter planoconvex lens, is used with coupling foil. The most common preferred site is between 11 o'clock and 1 o'clock position if the opening will be entirely covered by the lid, otherwise temporarily. Between middle one-third and peripheral one-third of iris over a large crypt or thin area. Since the wavelength of NDR laser is beyond the visible spectrum, helium neon aiming beam is used for focusing. 2 to 5 millijoules of energy is used. The iridotomy diameter should be at least 150 to 200 micrometer. A gush of fluid or pigments from the posterior to anterior chamber or lens visible through the iridotomy is considered as an endpoint. We have to check the intraocular pressure 1 hour after the procedure and ensure the patency of iridotomy. The most important complications are transient IOP rise, which can be contracted by topical bromelain before or immediately after the procedure. Anterior uveitis, for which we have to prescribe topical steroids for 5 days. Bleeding and hyphema during the procedure. Resistant bleeding can be stopped by applying pressure with the contact lens. Corneal damage, cataract formation, retinal injuries, and monocular blurring are other complications. Into case scenario 2. A 50-year-old female, known case of diabetes mellitus, came for regular eye checkup. On examination, right eye was found to be shallow anterior chamber with intraocular pressure of 18 millimeters of mercury. Left eye was within normal limit. Gonioscopy, right eye showed 270-degree angle closure, opening and indentation. Anterior pigmentation 1+, no peripheral anterior synechiae. Left eye showed open angles. On examination, both eyes were normal and there were no evidence of diabetic retinopathy. Moving to the management of primary angle closure suspect. The indication for laser peripheral iridotomy are if the patient has other eye primary angle closure or primary angle closure glaucoma, if there is localized patchy pigmentation of posterior trabecular measure or symptoms suggestive of intermittent angle closure. The patient requires frequent dilatation as like diabetic patients, or if there is family history of angle closure glaucoma, or if the patient is unable to follow up on a regular basis. If
So
visually
what are the
significant
symptoms that are suggestive of intermittent angle closure, any of the second years?
The presence of peripheral anterior synechiae and patchy TM pigmentation.
Patchy TM.
Symptoms. Okay. He will complain of episodes of blurred vision before and.
Sorry?
Any previous episodes or similar episodes of blurred vision or colored just blurred vision actually.
They can have intermittent headaches, intermittent colored halos. Okay. And when you see localized patchy pigmentation, that is a sign that previously there has been apposition, there has been contact which has been released. Yeah.
Yes, yes.
If visually significant cataract is present, lens extraction is an alternative. Risk of progression of primary angle closure suspect to primary angle closure is found to be 22%. Acute angle closure in primary angle closure suspect is rare at 0.1% per year and is likely to be higher when greater extent of non-visibility of posterior trabecular measure is there. Case scenario 3, a 60-year-old female presented with complaints of diminution of vision in the right eye. Right eye showed Von-Harvick's grading 1 and intraocular pressure was 32 millimeters of mercury in the right eye and 18 in the left eye. The gonioscopy showed angle closure with peripheral anterior synechiae and the right eye disc image and the visual field is given. The management of primary angle closure and primary angle closure glaucoma are almost similar. Once the IAPA is done, start the patient on medical therapy. If needed, laser peripheral iridoplasty can be done. Assess the patient for IOP control. If the IOP is within acceptable range and there is no cataract, patient can be followed up on a regular basis. And if there is significant cataract or if the medical treatment is not tolerated, phaco emulsification with or without trabeculectomy is the option. If there is poor IOP control with maximum medical therapy, or if there is progressive damage, assess the lens status of the patient. If there is cataract, phaco trabeculectomy, and if there is no cataract, trabeculectomy are the treatment options.
This is a simplified chart, so it can vary depending on a case-by-case basis. Even if the IOP is within an acceptable range and the patient is not tolerating medication, you may have to do a TRAB along with a TRAB. Similarly, if a patient is tolerating medication, is using medication and the IOP is within the acceptable range, if the number of medications used are less, you're more likely to prefer you will be preferring a cataract surgery, whereas if the patient is on maximal medication, you're more likely to prefer a phacotrab. Please continue.
So in short, the rationale of treatment once angle closure is diagnosed is to eliminate the pupillary block first, then assess the extent of residual angle closure, whether it is appositional or synovial, establish baseline features following iridotomy in terms of gonioscopy, optic disc and visual fields, follow up in terms of progression of these features. A few words about the treatment of Platelet syndrome. It includes topical IOP lowering agents, myotics like topical pilocarpine to prevent spontaneous pupillary dilatation. Other modalities include peripheral iridoplasty, phaco emulsification, filtering surgery with or without cataract surgery. Coming to the recent studies pertaining to the topic, I will be discussing Assumption Angle Closure Prevention Trial or SAP trial and Eagle study. The SAP trial is a single-centered randomized control trial conducted to assess the efficacy of laser peripheral iridotomy in preventing development of primary angle closure or acute angle closure in Chinese primary angle closure suspects. The inclusion criteria were patients of age 50 to 70 years with bilateral PACS, no primary angle closure or primary angle closure glaucoma, no peripheral anterior synegia, and IOP within 21 millimeters of mercury. Those patients with life expectancy less than 1 year or previous intraocular surgery or penetrating ocular injury, media opacity preventing laser peripheral iridotomy, best corrected visual acuity less than 20/14, IOP increase of 15 millimeters of mercury after dilatation or provocation test. These patients were excluded from the study. Among the two eyes, one randomly selected eye was assigned laser peripheral iridotomy and the other eye was kept as a control. A total of 889 patients were enrolled in this study. The primary outcome was measured in terms of incidence of primary angle closure by 72 months of follow-up. Coming to the results of the study, incidence of primary angle closure or primary angle closure glaucoma in laser peripheral iridotomy group was found to be 4.19 per 1000 eyes per year, and in the control group it was 7.97 per 1000 eyes per year. Prophylactic benefit of laser peripheral iridotomy was statistically significant according to the study. The incidence of acute angle closure was very low. It was less than 1% per year among the primary angle closure suspects and had relatively benign nature with no immediate threat to patient. In view of low incidence rates of outcomes with no effect on visual function, benefit of widespread use of prophylactic laser peripheral iridotomy for PACS is limited and hence not recommended. The study had few limitations. The definition of primary angle closure in the study included at least one glaucoma of peripheral anterior synegia on gonioscopy, so a percentage of actual PAC would have been missed. It's directly applicable to Chinese PACS population. Extrapolation to other population previously reported higher conversion rates of primary angle closure or primary angle closure glaucoma. The take-home message from the study is, in primary angle closure suspects, laser peripheral iridotomy is to be done in eyes with specific indications, as we have mentioned earlier. In other patients, All other patients must be regularly followed up with gonioscopy and also informed about the slightly high risk of acute attack and its symptoms. Coming to the EV study, it was an international randomized controlled trial to assess the effectiveness of early lens extraction for treatment of primary angle-closure glaucoma. The inclusion criteria were patients of age 50 years or above with no cataract, and those patients were newly diagnosed primary angle closure with intraocular pressure 30 or more, or newly diagnosed primary angle closure glaucoma patients. Those patients with symptomatic cataract or advanced glaucoma, history of previous acute angle closure attack, or previous laser or ocular surgery were excluded from the study. A total of 419 patients were enrolled for the study. Among them, 155 patients were primary angle closure and 263 were primary angle closure glaucoma. Among the 419 patients, 208 patients were assigned clear lens extraction and 211 were assigned to standard care group, which was laser peripheral endotomy with topical medical therapy. The outcome measures included patient-reported health status, intraocular pressure, and incremental cost-effectiveness ratio per quality-adjusted life year gained 36 months after treatment. Into the results, the mean health score was 0.052 higher, and mean intraocular pressure was 1.18 millimeters of mercury lower after clear lens extraction, and it was more cost-effective than the standard treatment. Study inference was clear lens extraction should be considered the initial treatment for primary angle closure glaucoma and primary angle closure with increased intraocular pressure. And the drawbacks of the study population included only patients above 50 years of age and PAC with intraocular pressure more than 30 millimeters of mercury, and excluded patients with mean deviation of less than 15 decibels on visual field. Hence, we can't extrapolate to the other population. Baseline indentation gonioscopy and follow-up gonioscopy data were missing in majority of the patients. And younger patients will not prefer clear lens extraction due to the loss of accommodation. Improved quality of life score was partially due to refractive error correction. There was a mean difference of only 1.18 millimeters of mercury between the groups, and the HVs were similar at final follow-up. From this study, we arrived at a conclusion that benefit of clear lens extraction in primary angle closure and primary angle closure glaucoma is still debatable. Considering the invasiveness of the procedure and the additional challenge of lens extraction in primary angle closure or glaucoma, peripheral endotomy would be a better option in primary angle closure or primary angle closure glaucoma eyes with clear lens. Coming to the next topic, aqueous misdirection. That's also known as malignant glaucoma or ciliary glaucoma. Incidence of aqueous misdirection following incisional surgery for primary angle closure glaucoma was found to be 0.6 to 4%. The risk factors for aqueous misdirection includes history of aqueous misdirection in the other eye, preoperative shallow anterior chamber, preoperative high intraocular pressure, nanophthalmos, and zonular laxity predisposing to anterior lens iris type. Coming to the mechanism, exact mechanism of aqueous misdirection is still unclear. Various proposed are posterior pooling of aqueous, which states that pooling of aqueous humor in vitreous focus causes forward displacement of lens iris or lens vitreous diaphragm. Cilio-lenticular or cilio-vitreal lobe. As we can see in the second image, tips of ciliary process rotate forward and press against the lens equator in phakic and against anterior hyaloid in aphakic patients, which causes obstruction to forward flow of aqueous, leading to posterior pooling of aqueous. Anterior hyaloid may contribute to cilio-lenticular flow, and break in anterior hyaloid near the vitreous space acts as a one-way valve, allowing only posterior flow of aqueous. And also abnormal slackness or weakness of zonules as well as the pressure from the vitreous is also involved in the mechanism. And currently the most supported one is the choroidal expansion theory, according to which an inciting event such as intraoperative inflammation or hypotony causes breakdown of blood choroid barrier, leading to the protein oxidation in extravascular choroid. This causes loss of normal osmotic force pulling fluid into the choroidal vessels and leading to choroidal volume expansion and increased IOP individuals. The features of aqueous misdirection are there will be shallowing or flattening of the central and the peripheral anterior chamber in the presence of the treated iridotomy. Those patients will be unresponsive or the symptoms aggravate with miotics and will be relieved with cytoplegic or iterative therapy. Most patients present with elevated intraocular pressure, and in case of trabeculectomy, some patients may present with normal IOP or lower IOP. Ultrasound biomicroscopy shows anterior displaced lens iris diaphragm and shallow central and peripheral anterior chamber, anterior rotated ciliary process, and ciliary effusion will be present or may not be present. The major differential diagnosis of aqueous misdirection are pupillary block, suprachoroidal hemorrhage, and serous choroidal effusion. The pupillary block, the AC will be shallow peripherally, and centrally it will be more deeper, whereas in aqueous misdirection it will be shallow centrally also, and pupillary block is relieved by laser peripheral iridotomy. Suprachoroidal hemorrhage is mainly distinguished by fundus examination, which shows bullous dark brown or red choroidal elevation, which can be confirmed by V-scan. And serous choroidal effusion, mostly the eyes will be hypotonic, and it's distinguished by fundus examination, which shows bullous choroidal elevation, and this can be confirmed. Coming to the management of aqueous misdirection, it's a step-wise procedure. In medical therapy, the cycloplegic is the first line of management. Cycloplegia will tighten the zonules and it will pull the lens back. This will break the ciliary. The most commonly used agents are atropine and onatropine 2 to 3 times per day. IOP lowering medications like topical beta blocker or alpha agonist or oral or topical carbonic anhydrase inhibitors, and if needed, IV mandrel can be used. Once the acute attack is broken, maintain the patient on topical atropine to prevent recurrence. Atropine is effective in 50% of cases in 5 days. If the medical management is not effective, we can go ahead with laser treatment or surgical management, which includes anterior hyalotomy using NDR laser, which inserts the anterior hyaloid phase, and pasplanar vitrectomy with or without lensectomy. Anterior vitrectomy with disruption of anterior hyaloid is essential to prevent the recurrence. Peripheral iridectomy and somnohyalotomy plus vitrectomy with or without mecanoemulsification restore the lens status, and cyclo-CKG is reserved for unresponsive cases with poor vision potential. There is a higher risk of developing malignant glaucoma in the fellow eye post-surgery. So preoperative prophylactic peripheral iridotomy can be done in PACD patients. IOP should be controlled preoperatively, and intraoperatively the anterior chamber should be maintained, avoiding the sudden decompression and anterior chamber fluctuations. And postoperatively, these patients can be put on atropine.
Okay, Catherine, I'll just put on my slides for case scenarios. Can you just stop the presentation? Are the slides visible?
No, ma'am.
No?
Yes, now it's visible.
Now,
Okay. Okay. Just give me a minute. Okay, just tell me when you see it on full screen. Is it full screen now?
Yes, ma'am, it is.
Okay, so we'll just do a quick recap using a few cases. I'll just give you a description. I'll not tell you the management or the treatment. You'll have to tell me what needs to be done. Okay, so I'm not reading it out to you. Maybe Catherine can read.
Yes, 50-year-old male.
1 second, please.
Hello?
Your voice is breaking like anything, so it's better
Yes,
Reni does the reading. The entire presentation, we haven't been
Okay,
able to
ma'am,
hear
I'll
anything properly.
present.
So, Reni, you go ahead.
Okay, ma'am. So this is a 50-year-old male, and you can see the IOP values as well as the refraction. There are two gonioscopy pictures that are there. That is put one without indentation and one with indentation. As you can see, you could see the anterior trabecular meshwork in all the quadrants in both the eyes, which open to the scleral spur, and both eyes were opening easily with compression. So in a scenario of this patient, these are the disc photos. What would you suggest with this? Do you need additional information for the patient? And if so, you tell me what all you need, as well as if you don't need, you tell me the diagnosis and the management. Okay. Is someone volunteering?
Ma'am,
Okay, is someone there?
Pallavi here.
Yeah. Yeah, tell me.
Ma'am, it is a case of primary angle closure suspect, but on fundus, on the color fundus photograph, the both discs look healthy. There is a cup disc ratio difference in the right and the left eye. We'll take the history of if the patient is diabetic and we don't have still seen the diabetic changes to rule out any condition where we have to dilate the patient again and again, or will he be able to come in regular follow-ups to us?
Okay, so what do you want? You want a history of diabetes, and the fundus you can see. You can't see any obvious diabetic changes anyway. So,
yes, ma'am. Still not there. And we'll ask the patient if the patient can regularly come for a regular follow-up with us.
Okay, so suppose the patient is not a diabetic and the patient is willing to come for a regular follow-up, what do you do? So this patient is, the patient had bronchial asthma, no history of diabetes, and additionally you should also ask a family history of glaucoma. There's no family history of glaucoma. As you can see, the fields are within normal limits. And the patient, if willing to follow up regularly with a gonioscopy at each visit, you can follow up the patient. There is no need to do a YAG-PI for the patient. Okay. This is the second case scenario. A 69-year-old female who complained of decreased vision while reading. A known case of nanophthalmos who came with outside reports showing an axial length of 18.56 millimeters in the right eye and 18.72 millimeters in the left eye. She's status post both eyes YAG-PI and both eyes status post phacoemulsification. She has hypercholesterolemia and ischemic heart disease. And this is the refraction and the IOP. So, yeah, the gonioscopy, this is the indentation gonioscopy that is shown here, showing closed angles in all quadrants. And the fundus image shows a pale disc with a spontaneous, with the arterial pulsation in the right eye, and the left eye, the disc was healthy. So, what do you want to do next for this patient? No? Yeah, hello, please answer.
Ma'am, it's primary angular glaucoma in the right eye. First, I would like to.
You say it is primary
IOP
angle closure glaucoma. Why do you say it is primary angle closure glaucoma?
Ma'am, because there is a the optic nerve damage is there.
Yes, there is glaucomatous damage, let's say. Suppose you say there is glaucomatous damage and the eye pressures are in 60s.
60s, ma'am. So, ma'am, I would like to...
and I've also mentioned the central anterior chamber as well as the peripheral anterior chamber is shallow.
Shallow, yes, ma'am.
Yeah, so...
so, ma'am, I would like to first lower the IOP.
No, your diagnosis is wrong. That's why I'm repeating the findings to you again. So, is this the patient? Does anyone else have a different answer? Yes, please tell me.
Misdirection syndrome. Ma'am, the patient is nanophthalmic. There's a patent YAG-PI in both eyes. But and the anterior chamber depth is shallow throughout.
Okay, so nanophthalmos is a risk for malignant glaucoma. The patient has
Glaucoma,
already
yeah.
had a cataract extraction. Okay, and additionally in the retinoscopy, you can see a myopic shift. All right,
Yes,
a myopic shift of minus 6.5 indicates that the iris lens diaphragm is moved forward. Okay, and yeah,
yes, ma'am.
so this was the image of the patient. So as you can see in the UBM of the right eye pictures, you can see a central shallowing as well as the peripheral shallowing, and the lower picture showing anterior rotation of the ciliary process. The extreme right picture is a deeper anterior chamber, in a central anterior chamber in the eye, in the left eye, which is not affected by this. So in such a patient, you have to give medical therapy. You can you can give atropine, and additionally, since it's a pseudophakic patient, you do a YAG hyalodotomy. What site would you prefer to do a YAG hyalodotomy? See, the aim of your hyalodotomy is to, if there is any trapped iris, you want it to go into the anterior chamber, right? So ideally, keep it away from the site of the, if you see any posterior capsule beyond the optic of the lens, that is an area that has only the PC, you can do a hyalodotomy there. Or else if you have the dialing hole of a lens, you can do it through that. Okay, so that would be a better option. And this is a case of a 44-year-old male with history of intermittent pain in the eye, both eyes, history of YAG-PI 3 years ago, a diabetic, presenting with refraction as shown, and an applanation before and after dilation as shown again, and the gonioscopy with and without indentation. Just take a look at it. And these are the disc photos of the patient. So, does anyone have a diagnosis? Anyone volunteering?
Primary angle closure.
Primary?
Primary angle
Angle?
closure.
Which eye?
Primary angle closure of OD, right eye.
Okay, then what is your diagnosis in what is your diagnosis in OS?
OS. OS is primary angle closures.
Is?
Both. It is
both eyes, I think.
Sorry? Not clear. Can you please repeat what you just said?
It is the primary angle closure in the right eye and a primary angle closure suspect in the left eye.
Okay. Would you think of something else also?
Is it plateau
a plateau iris? Plateau iris.
Plateau iris we can keep as a differential because patent PI is there and still IOP is raised.
When you call it a plateau iris syndrome, when a patent PI is there and IOPs?
Patent PI is there and after dilation there is a spike.
Yeah, after dilation the spike should be there. You don't call it plateau iris syndrome just if there is a patent PI and the IOP is raised. Okay. So in this case, you can see that the post-dilation applanation has been there. And additionally, when you have a young patient, okay, yeah, relatively younger patient, you must always look for this. What sign will you look for in gonioscopy?
For the double
hump sign.
Okay, what is the double sum? I mean, what causes the double hump sign?
One hump is because of the lens. The other one is because of the anteriorly displaced iris.
Why is the iris anteriorly displaced?
Due to the rotation of
in the periphery, it is one is in the periphery. Yeah.
Yeah, because
so when you do an indentation, you look for the double hump sign, which is caused by the anteriorly placed serially processed in the periphery, and the second hump being due to the lens. Okay, and in this, both the discs are fairly healthy. So the patient was put on. Okay, this is a what image is this? Sorry.
Yes, okay.
Yeah, it is an ASOCT. So can you use ASOCT to, which one would you prefer, an ASOCT or a UBM in case of a plateau iris?
UBM, ma'am.
UBM, because it will also give us information regarding the iris and ciliary body.
You can see the iris position here, no?
No, the ciliary body cyst and everything.
Yeah, you cannot see the ciliary body. So, but you, though you can see that the iris and that the peripheral angles are shallow and that the angles are closed and there is no pupillary bowing. All these things can be seen, and there is no increased lens vault. All this can be seen, but you cannot see the ciliary body or the ciliary process. So in case of a plateau iris, it would be better to have a UVM. We have an anterior rotated ciliary process, absence of the ciliary sulcus, and then a peripheral, a very shallow periphery compared to the center, and there is no bowing. Okay. So in all young patients with angle closure, you must definitely make sure that there is no plateau iris. In this patient, since the IOP was elevated in the right eye pre-dilatation, the patient was put on AGM in the right eye despite a healthy disc. Okay. And this is the fourth case. A 12-year-old male presented with the refraction as mentioned of accepting minus 8.5 in both eyes, improving up to 6.9. The child was using dorzolamide thrice daily and a combination of dimetapros plus timolol once at night. The anterior segment diagram shows scattered pars, a clear lens, and an increased lens vault. And the compression indentation gonioscopy shows pars in all quadrants and closed angles in 2 to 3 quadrants in the right and the left eye respectively. The IOP, I can't read the IOP. Can someone, it was 19 in both. Yes.
19 in both.
Yeah. Okay. So can you, and these are the disc pictures of the patient. So what is it and what next? And do you want something else? Diagnosis?
Primary angle closure.
11-year-old child.
He would.
12-year-old child.
No.
Okay, I'll give a hint. You can see that in the anterior segment picture, they've mentioned an increased lens vault. And in the refraction, you can see a high minus. Can someone come with the diagnosis?
Micro.
Anybody? Just guess.
Micro.
So in very young patient, yeah, please sir. Okay, so in very young patients, don't directly jump to primary angle closure, suspect closure and glaucoma. Okay, you can see a high minus value in the side. So something is there that it could be an incidental myopia or it could be something that is causing the myopia other than the long axial length. All right. And this child had closed angles in all quadrants. So you have to take a look at this. Can you, okay. So when you see the lens thickness has been increased and the AC depth is shallow, and on UBM you can see shallow central AC and a thicker lens for the age of the child and the equatorial diameter of 6 and 5.71. Can someone give me the diagnosis now? See, if you have an equatorial diameter of 6 millimeter or 5.71 millimeter, once your eye is fully dilated, you will be able to see the rim of the lens within the pupillary area. Any guesses?
Microspirophakia, ma'am.
Yeah, good. It's a microspirophakia. Okay, and so in young children, the few things that you must know is the myopic refraction and the increased lens vault. Can you name another condition in which child can present with angle closure due to a lens related or eye related issue?
Any ectopia lentis can also present like this.
Okay, well, no subluxations, no dislocations.
Nanophthalmos, ma'am.
Yeah, an anophthalmos, what is there in an anophthalmos? The axial length is reduced, but the lens dimensions are normal, are the same as in normalized, but the axial length is severely reduced, as a result of which the lens protrudes into the anterior chamber, and then you have angle closure. Okay, so there are several other things as associated with this. In this case, a YAG PI was done. The patient was continued medication, and IOP was controlled on medication, and the child was also given glasses and asked to continue. Okay. So these are the case scenarios.
For the PGs, any precaution to be taken in PIs in these patients, microspirophakics? Anyone? Before the PI? Something you will not instill?
Not with myotic, you will not instill.
Yeah,
because the
Philo.
Because they
yes.
contraction and they cause further slackening.
Because the lens is already.
Sorry, what? Lens?
Ma'am, myotics may cause ciliary muscle contraction. Therefore, zonules will be slackened further. That may cause further pupillary block and spike in IOP.
Yeah, it can precipitate acute angle closure attack in these patients. That's why you will avoid.
Yes,
and in one previous case, that plateau iris syndrome, you saw the gonioscopy. So there you saw that it was ATM, and on indentation it was PTM. So if after a PI you are still requiring a indentation to open the angles which are not synechial, the closure was only appositional, then you should not utter primary angle closure at all. Okay. See, if it was angle closure, then the angles would have opened up after a PI. Yeah, so once you still need indentation, it is plateau iris. Yeah, thank you.
Okay, if there are no doubts, then we can end the class. Thank you, everybody. Thanks, Catherine.